So the next thing we're talking about are tracheostomy tubes. So a tracheostomy is when the doctors go in and they cut a hole here beneath the larynx into the trachea. The hole is called a stoma. And then they insert, you can see in a picture here of this metal tube, although they're usually not metal these days, but sometimes they are. But they insert this metal tube into the trachea, and it usually passes between the second and third tracheal rings, and it allows for appropriate suctioning out of any mucus that might be in the airway. The tracheostomy tubes are better at allowing the patients to speak and eat appropriately because you don't have anything passing between the pharynx and the airway, so there's no endotracheal tube keeping the vocal folds open, keeping the epiglottis from sealing appropriately. And tracheostomies can be placed for different reasons. Usually if a patient has a compromised airway or they're trying to wean them from the endotracheal tube, but they still want to have them on a respirator for a longer period of time. So the tracheostomy tubes, they can be left in on a much more permanent or semi-permanent basis without being too destructive. And the tracheostomy tubes come in different sizes, and the size of the tracheostomy tube is usually determined by the size of the patient as well as the needs of the patient. And here's an example of a patient with a permanent tracheostomy.
Just gotta meet Ashley.
I have known you since you were a baby, right? And how old are you now?
Yes, I just turned 21.
Ashley was one of my very first ventilator-dependent patients, so I was a very young attending when she was a newborn, and I met her during her first year of life. She has an amazing attitude towards life and has from the very first moment she could speak. I always knew when she was coming to clinic when she was a toddler because she would be singing the entire time. And her grandmother and I would have to struggle to get a word in edgewise because she was very verbal from an early age and just super sunny personality and very interested in the world around her. Just a real joy from the very beginning.
One of the reasons that makes me so successful is having the support of my family. Constant support every day. Love it. I love them for it.
So one of the things you're seeing is that she's having to wait for expiration to speak on.
So they give me a very positive attitude because they've never told me.
And her speech is sort of interrupted by the machine as it's doing its work. So the larger the tracheostomy tube is, the less space you have to breathe around it. The smaller the tracheostomy tube is in the trachea, the more space you have to breathe past the tracheostomy tube, and the less air you're going to be able to get in and out of the tracheostomy tube. So downsizing the tracheostomy tube is a strategy the doctors use to wean patients from their tracheostomy. Because when the patient has gotten to the point where the doctors think they can breathe on their own, they don't just rip out that tracheostomy and see if the patient's able to breathe without it. It's a stepwise process that usually begins with them putting a cap on the trachea and seeing if the patient can breathe past the vocal folds. And then the amount of time spent during the day with the tracheostomy capped will slowly increase as the person gets more adept at breathing without the tracheostomy tube. So here are the three main parts of a tracheostomy tube. You have the outer cannula, and this is the main plastic piece that sets in the patient's airway. you have what is known as an obturator. And as you can see, the obturator fits into the outer cannula and it creates this little pointy end. And so the obturator is used by the doctors. They put it in to place the tracheostomy tube through the stoma into the trachea. But at that moment, with the obturator in there, the patient can't breathe. So the doctor quickly pulls out the obturator, and that opens the outer cannula. But you want the patient to be able to clean the tracheostomy tube. You don't just leave them breathing through the outer cannula alone, because they cannot remove the outer cannula to clean it. You have the inner cannula that the docs then place. And then, so they're breathing through the inner cannula. And once or twice a day, they pull out the inner cannula. And they're able to clean all the mucus and gross stuff and anything that might be threatening to obstruct the airway, and then put it back in. So as we mentioned, one of the benefits of the trach over the endotracheal tube is that you're probably going to be allowed to take food by mouth. So looking at this model, you can see, so here's the oral cavity, the tongue, the pharynx, the epiglottis, vocal folds. This is the trachea. This is the vocal folds. So trachea, and here's your tracheostomy tube. So looking at this, you can see there's nothing major prohibiting a person from swallowing when they have the trach placed. So here is a video of a FEES evaluation with the trach in place.
Dysphagia is really common in tracheostomized patients, and quite often there are lots of reasons why patients have swallowing problems, and they can be quite complex. So having an early swallowing assessment from speech and language therapist is so vital, because consequences of not picking up swallowing problems leads to worse outcomes for patients and often prolonged length of stay. What we're trying to work out is why they have a swallowing problem. If we can work out why, we can work out what to do to fix it. The best and most accurate assessment tool is FEES. FEES is fibre optic endoscopic examination of swallowing. This involves a speech and language therapist passing a nasendoscope along the nose to the back of the pharynx in order to look at the larynx, look at the vocal cords, look at secretions, and look at the swallow. It's also really, really helpful for the whole MDT management of the wean. And if we pick up intubation trauma and edema and vocal cord palsies, this can actually affect what we do in terms of weaning and decannulation. We can actually give the patient food and drink with the scope in and see how at risk they are of aspiration. When we don't know if silent aspiration is occurring, what people tend to be is a little bit more cautious and keep patients nil by mouth. So if we've got much more accurate assessment, we tend to progress people onto oral feeding, even if it's only as few sips of something. If we're able to get people eating and drinking sooner, then generally speaking, they get out of hospital quicker.
One of the things that I want to tease out that she said is that basically just because the person has a trach, you want to go in and evaluate them with their trach to see if you can detect any swallowing problems. Because if they don't have any swallowing problems, then you can start giving them food by mouth sooner. And the sooner you can start giving them food, or as she said, even a few sips of water by mouth, that's going to keep the swallowing mechanism more active. That's going to keep all these muscles from becoming atrophied and from more problems arising. that are the result of going a long time without using the swallowing mechanism. So, taking food and liquid by mouth is possible with the tracheostomy tube. That doesn't mean it's not without its complications. So there's a lot of different configurations of the tracheostomy tube, but if you have the tracheostomy tube placed and if you see this little balloon here, this is called the cuff, and as you can see, that seals the airway around the tracheostomy tube. So the only air going in and out of the lungs would be passing through the tracheostomy tube. So there is no air coming up through the vocal folds, through the airway. So there's no sense of smell, or a very decreased sense of smell, because there's no inspiration through the nose. There's decreased sense of taste, because there's no air coming through the nose or air passing through the oral cavity. There's the possibility of infections happening at the site of the tracheostomy, and that is common. There is increased secretions of the body because of this basically open wound of the stoma, as well as the irritations caused by the tube itself. And if you have the cuff in there, then that's going to be irritating the trachea as well. If there is enough of an irritation between the tracheostomy tube and the posterior wall of the trachea, it could break down that tissue on the back of the trachea and could cause a condition known as tracheomalacia, in which during expiration, basically the trachea collapses. And if the trachea is collapsing during expiration, then you're going to have Bernoulli sucking it closer together, occluding the airway, which is going to make expiration more difficult and more effortful and more scary. And if that continues long enough, it can cause the trachea to collapse entirely. And there can also cause a hole or a fistula to occur between the trachea and the esophagus. So a fistula can occur here, which is known as a tracheoesophageal fistula. And if that happens, then you have the possibility of food that is going down the esophagus being aspirated into the airway through that fistula between the trachea and the esophagus.